So hi everyone, my name is Julia Maeda. We're pleased that you all could join us for this week's lecture of the 12-week didactic series. If we could get next slide. This series brings you lectures from experts in the field covering different topics each week. Next slide. The Neuropsychology Didactic Series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities for the international neuropsychology community. Next slide. We would like to thank our sponsors for their financial support for the series, including APA's Committee for Early Career Psychologists, the American Psychological Association of Graduate Students, or APAGS, the Association of Postdoctoral Programs in Clinical Psychology, or Neuropsychology, or APSIN, the International Neuropsychological Society, INS, and the Society for Clinical Neuropsychology, or APA's Division 40. Next slide. Before we start, here are the disclaimers for the series. This training is not meant to replace or formal education in neuropsychology, and the views of the speakers are their own and do not reflect the official endorsement of any institution or organization. Next slide. Questions for our speaker can be submitted via the Q&A box on the lower left hand of your screen next to the chat box. We will address questions submitted to the speaker during the last 10 minutes of today's talk, and a recording of today's lecture will be provided later this week on our website. Now it is my pleasure to introduce and to welcome back Dr. Scott Sperling for today's lecture on Parkinson's disease, cholinergic denervation, and non-motor symptoms. Dr. Scott Sperling is Associate Professor of Neurology and the Associate Neuropsychology Training Director at the University of Virginia. He completed his doctoral training at the Wright Institute in Berkeley, California, and his clinical internship at the Jesse Brown VA Medical Center in Chicago. He is a productive clinical scientist with a history of funded research in multiple areas, including investigations related to evidence-based dementia care and cholinergic denervation in Parkinson's disease. Dr. Sperling is also an active educator and mentor who is dedicated to the development of students and early career psychologists. He is the chair for the Society for Clinical Neuropsychology's Education Advisory Committee and the vice chair of APA's Early Career Psychologist Committee. So without further ado, I'll turn it over to Dr. Sperling.
Thank you. Before we dive in today, I just wanted to take a few minutes here. The Neuropsychology group has been talking recently about the events that have happened within our country, not just in the last few weeks here, but long before that. I can say that I know personally it has been quite a struggle for myself to be coming into work, to be focused on patient care, writing papers, you name it, in their current climate. And I can say that as a white man with a heck of a lot of privilege. We say that here to acknowledge that many of you are surely going through the same thing, and that for those of you who are people of color, I can't quite imagine the added stress and pressures and struggle that it is to certainly be existing within our society today, let alone to be trying to move through with training and education in this already difficult climate. So we know that words cannot make the ills of our society disappear, but nonetheless, we certainly wanted to acknowledge what is going on here, acknowledge all of you, and let you know that through some of the discussions we've had quite recently, our group here is going to be taking some very concerted efforts to make sure that we are attending to issues of diversity and social justice. First and foremost, we support Black Lives Matter. We denounce racism in all of its forms. And we're going to be working within our committee to further increase the diversity representation within our neuropsychology committee. We've also made a commitment that at least 1 out of 4 of our invited speakers are going to be from a non-dominant culture, and that all of our speakers are going to be required to present information related to non-dominant cultures, cultural disparities, or inequities. and that we will be also focusing on providing lectures to increase advocacy and education for and about social justice issues. Now, awkward of switching gears here to Parkinson's disease. Just a couple quick disclosures. Some of the work that I'll show you towards the end of the presentation is funded from the DoD and the Virginia Alzheimer's and Related Disease Research Award Fund. For our learning objectives today, the goals here are going to be to provide some education so that we can understand how pathological heterogeneity contributes to unique PD symptoms and PD subtypes. We want to gain an understanding of the relationship between Ch4 gray matter density, or the basalis nucleus minor, and cognitive deficits and cognitive decline in Parkinson's, as well as the associations between Ch4 degeneration and psychosis and apathy. I'm going to start off just with some background though. So PD is common, right? Parkinson's, there's over 6 million people worldwide, and about 930 some odd thousand people in the US have Parkinson's disease. Okay. The first known kind of work or description of Parkinson's disease is back from 1817. It's fairly phenomenal if you think about Dr. Parkinson's description of the disease back then and how it really holds true in terms of our understanding of the primary motor symptomatology in the disease today. PD is a clinical diagnosis, okay? Meaning that, like most of our neurodegenerative diseases, we're not able to take a blood test or have imaging that confirms definitively a diagnosis of PD. A neurologist is going to make this diagnosis based on the core clinical features of a neurological examination. We're really looking for the cardinal symptoms of bradykinesia with resting tremor or muscle rigidity. And often we see that postural instability is a core feature of the disorder. Right. But we know now, we've known for a while, but I think there's increasing evidence and I think hopefully an increasing appreciation more recently that Parkinson's disease is not just a disease of motor symptoms. It's a very complex syndrome where the non-motor symptoms of the disease are quite common. They can occur really at any point in the disorder, years actually before the motor symptoms manifest through the late stage PD. And they can vary from individual to individual, and within individuals, we see quite a big mix between which symptoms present and how severe they are at any one point in time. But so essentially what we're saying is that the PD is really this complex syndrome where non-motor symptoms are part and parcel of the disease, and not just something that happens to some individuals some period or some of the time. Some common non-motor symptoms really include hyposmia, or that lack of smell, which can be a really early biomarker for the disease, as well as a range of different autonomic symptoms, certainly constipation and urinary urgency, orthostatic hypotension, and certainly sleep dysfunction. This could be REM sleep behavior disorder, excessive daytime sleepiness, or difficult sleep maintenance. We also see a range of neuropsychiatric symptoms, right? So there's quite a broad literature demonstrating that depression, anxiety, and apathy are quite prevalent from mild to more severe symptoms. We see a significant impulse control disorders in some individuals in relation to dopamine and dopaminergic medication. And psychosis, which itself is, and we'll talk a little bit about this later, not just one thing. We, I think, commonly think of frank visual hallucinations as being a common feature of PD, and it is. But we also see a range of other psychotic symptoms, from visual illusions, sense of, of light or shadows and movement coming from the periphery. You can see a sense of presence as well, this sense that somebody might be in the house or the room when you're not really there. So really a plethora of different psychotic symptoms that range from, quote unquote, benign to more severe. And then certainly there's cognitive impairment, as was the case with most of our neurodegenerative diseases, right? We know that there's a continuum here where there's folks with Parkinson's without cognitive impairment, those who go on to develop mild cognitive impairment, and then certainly those who develop PDD or PD with dementia. But the point that I'll be trying to make here is that, cognitive impairment is, as with our other neuropsychiatric symptoms, quite common. And it's not something that simply happens only later in the disease stage, right? So there's good evidence that anywhere between, 15 to 20, 30% of folks, if you actually perform a good cognitive workup at the time of diagnosis, would actually meet criteria for PD-MCI. So these are individuals that are coming into the office that don't necessarily have cognitive complaints. That's not why they're presenting. They're seeing a primary care physician or neurologist for the first time because of new onset tremor or other motor symptoms. Yet again, at assessment, or if assessment was done, they would certainly have a high rates of having cognitive impairment. About 10% of these folks are going to develop dementia annually, such that the lifetime prevalence of dementia and PD is 80%. So in essence here, the rule instead of the exception is that if you're going to live long enough, there's a much higher likelihood of developing dementia. So I think we really need to be considering, Parkinson's disease as a disorder where cognitive impairment, again, is the rule and treated as such. So I'm speaking to the choir here, but we know that there are a host of different cognitive abilities and cognitive domains. And I think for most of you, when we tend to think about Parkinson's disease, or at least the way that I think it's taught most often, is that it's a disorder really typified by deficits in executive functioning. So we see problems with working memory and planning, maybe psychomotor speed as well. And this is certainly true. But I think what is important to remember is that PD, like the motor symptoms, or PD cognitive impairment, like the motor symptoms, is quite heterogeneous, okay? So if you see, there's a lot of studies that show this now, but some seminal work by Goldman back in 2013 now will show that although executive impairments are common, that it is extremely common, in fact, to have multiple domain cognitive impairment. Okay? So if you see here this group of folks, if you want to just understand whether there is a single or multiple domain cognitive impairment across this sample, about a third had 3 domains impaired, and about a third had 4 cognitive domains impaired. And you can see that you can look at this basically around the different cutoffs. Anywhere from 1 to 2 standard deviation cutoffs as in terms of impairment. At the 2 standard deviation cutoff, which at least in this sample was found to have the best balance between sensitivity and specificity, the vast majority of patients had multi-domain cognitive impairment. So, the point of this is that we need to think about Parkinson's even early on as one where it's not just this single domain executive impairment, but it's that and then some, which then begs the question is what is contributing to that and then some, which we'll get to in just a minute. Just so we're grounded though, so just from some fundamentals in the background, right? So Parkinson's disease, you want to think about, what it is from a biological standpoint, right? And we're talking about a synucleinopathy, right? So just like Lewy body dementia, MSA, and PD, we can go to the protein, and we know that alpha-synuclein is implicated here in the disorder. And what we can see is that if you're going to look at the hallmark, pathological characteristics of PD, we're really talking about Lewy bodies, right? And so these are abnormal intraneuronal aggregates of protein, primarily made up of either phosphorylated or misfolded alpha-synuclein, again, so found within the body of the neuron. Okay, and these are typically found in the substantia nigra, but they can also be seen in other areas of the cortex. And in addition to the Lewy bodies, we think about Parkinson's, you're thinking about dopaminergic denervation, right? Or, problems with dopamine. And we see here some of the earliest signs or symptoms of PD happen because of that dopamine loss. So if you look at the upper right-hand side here, we have this really, we're going to nerd out a little bit, this beautiful purple pigmentation here in the substantia nigra, which reflects intact dopaminergic neurons. And in this patient with PD dementia down on the bottom right side, we see that loss of purple pigmentation representing a loss of the dopaminergic neurons. And anywhere from like 80 to 90% of dopaminergic neurons can really be lost at the time of, even at the time of diagnosis. So these pathological changes are happening very early on in the disorder before even symptom manifestation. And what happens here is with the loss of these dopaminergic neurons, it has, as you'd imagine, this downstream effect on multiple functions due to a different dopaminergic kind of loss of innervation through multiple dopaminergic pathways. So this nigrostriatal pathway, you can see, is what we commonly or most commonly think about in terms of being affected in PD. And the loss of dopamine through this pathway has a really significant role in the manifestation of the motor symptoms of the disorder, whereas loss of the dopaminergic innervation throughout the mesiolimbic pathway really has quite a significant effect on reward behavior and tends to have greater degeneration in folks with more advanced disease or PDD. And then also you can see the effects of dopamine loss through the mesiocortical pathway, where we see that loss of dopamine to the frontal cortex affects things from executive control to motivation, learning, and other cognitive abilities. So these are clearly, this is obviously well known. These are sort of, clearly big pathological, markers and have effects for PD, both from again a non-motor and a motor standpoint. But what I'm going to argue is that we need to really be stepping back and from a purely dopaminergic centric standpoint and thinking about PD as one that can really be typified by sort of multi-neurotransmitter dysfunction. Okay, so if you look at the top side here, we have, this is noradrenaline. On the bottom left, you have serotonin pathways, and in the bottom right, you've got cholinergic pathways. And I'm not going to go through all this for you, but this is just to show that clearly when there's a loss of these neurotransmitters, that it can have broad effects through these projections throughout the brain, throughout the cortex, and that it is clear within PD that although again there's heterogeneity between individuals, there's certainly a large number of folks that have a loss of these neurotransmitters, again, noradrenaline, serotonin, acetylcholine, that can have a significant effect on functioning and really lead to a manifestation of multiple different symptoms. I'm going to talk about the cholinergic loss in just a second, but I'll step back from that just a little bit because I want to just kind of go over some subtyping. And this is really just because there's been a lot of emphasis, I think, certainly in the PD world lately about sort of these PD subtypes, right? Initially, a lot of the work that was done was really case studies or case series, really basic observation. I'm trying to identify these really different clinical subtypes of the disease. And it was proposed that there's sort of these, basically these manifestations can come through come about because of three different routes of pathology through the brain. We see here this brainstem olfactory route, where we can have this, late onset hyposmia, and it can really lead to folks who have really significant sleep dysfunction, where you have excessive daytime sleepiness or REM sleep behavior disorder, or an autonomic dominant subtype where you really get that significant postural hypotension and issues with urinary symptoms or intestinal symptoms as well. Then there's this sort of olfactory route that was proposed where you really see this more, these more effective symptoms, right? So you get folks that are either incredibly anxious or anxious and depressed, or more of a pure major depressive syndrome, or folks that can have some of these sort of less common but reported subtypes where there's like this fatigue dominant or pain dominant subtypes as well, thought to be tied to greater deficits in serotonergic denervation. And then there's this group that's been described from time now that looks at greater cortical deficits, really this cognitive phenotype, where these are individuals that are getting diagnosed with PD later on, and at or around the time of diagnosis are have more substantial cognitive impairment, if not frank dementia, also higher rates of apathy. So these were all described early on. But as I was saying, that a lot of this kind of early work was really clinical observation. And where I think fortunately the field has moved in the last handful of years is to more scientific or data-driven approaches, looking at essentially cluster and factor analysis to better understand, do these observational studies really hold good weight, and can we really parse out these different disease subtypes. The other, emphasis, I think, for a lot of folks that are undergoing this work, looking at PD subtypes and incorporating the non-motor symptoms into this, is because we know that initially on, our characterization of what PD subtypes were was really, purely based on motor symptoms, where we had this group who were either, called tremor dominant, or those who had more significant postural instability or gait dysfunction, the PHED subtype, or this mixed group. And the issue with those particular motor subtyping is that a lot of those folks would pretty quickly move into a mixed subtype, after they were categorized, and that means there's not a whole lot of value there from the clinical side point when you're talking about prognosis, and I think importantly from a clinical research, or clinical trial design, if you have unstable subtyping, it doesn't do you a whole lot of good. So the notion here is, can we really incorporate more of the non-motor symptoms into the fold, and see that if by doing so, can we actually arrive at stable subtypes of the disease that can be identified early on and tracked over time. And so one study from Van Volkman, the factor analysis, looks at just this. They came up with 5 different subtypes in their group. So one you have here in this first group with really mild motor and non-motor disease. A second group that had pretty poor postural and gait instability, hyposmia, and hypotension. This third group that was what you would typically think of as that tremor dominant, right? So there's severe tremor, but not much else going on. A fourth group that had very severe REM sleep behavior disorder and also pretty poor psychological well-being. And then a fifth group that was just fairly malignant across the board when we're talking about both non-motor and motor features. Okay. And this has been done by others over time. I'll show you just another study here where, again, we're looking at these clusters of symptoms, essentially. And if you look at cluster 1 in this group in green, right, we have another individual subtype that is basically mild, right? So these are folks who tend to be a little bit younger, mild motor symptoms, mild cognitive and affective symptoms as well, okay? In red, though, we see individuals that have, let's go in blue, in cluster 3, we've got individuals that motor symptoms are a little bit more progressed, but not all that severe. And if you look at from a cognitive standpoint, there tends to be much more executive dysfunction, as well as a plethora of affective symptoms like depression and anxiety, a degree of psychosis. But what we would typically think of as these kind of quote unquote posterior cortical cognitive abilities like language and memory are less affected essentially. So this group really is that kind of prototypical, PD group that you kind of tend to think about or you read about in your textbooks, right? So the thought is that there's real cholinergic dysfunction here that's driving the motor symptoms and really that executive dysfunction and the depression that you see in the disease. This can be contrasted against this cluster 4, where there's more severe motor symptoms. And then really importantly, from a cognitive standpoint, there's actually a less executive dysfunction and a more significant posterior cortical cognitive issues, including problems with semantic language and memory. And the affective symptoms tend to be more pronounced as well. And you can see a more severe apathy and different flavor of psychosis as well. Okay. And then this 4th cluster here in red, where again, similar to the slide that I showed you before, there's just more malignant disease and there's just severe symptoms from a motor or non-motor standpoint across the board. All right, so the thought there here is I told you that cluster 3 in blue is really this dopaminergic denervation. Wow, and the cluster 4, we think that this could lead due to cholinergic denervation, which we'll talk a little bit about, right? So individuals that have more cholinergic loss early in the disease tend to have more of these posterior cortical deficits that can lead to these memory impairments and psychosis. And that either cluster 3 or 4 can over time progress to be cluster 2, where you see this, again, multi-neurotransmitter dysfunction leading to greater impairment. And it's also likely that that cluster 2 just has simply a higher load of cortical Lewy bodies as well. Okay. So we're talking about cholinergic denervation. We're talking about acetylcholine here, right? So what is it? It's a essentially ubiquitous neurotransmitter that has a pivotal role in the chemical neurotransmission in both the CNS and the PNS. And it's been implicated in a host of symptoms, everything from cognitive dysfunction to RBD, hyposmia, and some work that I'll show you in a little bit as well that gets at psychosis and apathy in PD. There are essentially 2 main cholinergic tracts in the brain. Okay, so there is this. Excuse me. There's essentially a brainstem and magnocellular basal forebrain tract. We'll focus basically on this this basal forebrain tract here, which you see in purple. And the reason that's important is that this within this area you see multiple structures, including the nucleus basal minor, or Ch4 as I've been referencing it. And in here you see this the neurons within that region, about 90% are cholinergic, and there's widespread projections from this region throughout the cortex, including certainly the frontal cortex and the parietal cortex, as well as to the amygdala. So what happens essentially is that when you lose the cholinergic neurons within within Ch4, that leads to this downstream loss of acetylcholine throughout the cortex to regions that are clearly implicated quite heavily in a host of cognitive functions, as well as different affective and emotional kind of personality abilities or traits as well. So we've known for some time now that cholinergic denervation is important. And if you look at some of the earlier work, you actually look at Alzheimer's disease, we know that Ch4 is an area where it's you can see some really early changes. It's a sort of an early hall biomarker for AD. And then actually, if you look at folks with Parkinson's disease dementia, right? So this is a later stage disease, or folks with dementia with Lewy bodies, even though there's been a lot written about sort of the cholinergic loss in AD, that in PDD or DLB, there's actually greater cholinergic loss than we see even in Alzheimer's. can be shown imaging as well. All right, so this is a SPECT imaging. So we're really looking at the kind of cholinergic networks, and these are folks with Parkinson's disease, dementia. And essentially we're looking at spatial covariant patterns here that represent the difference between individuals in these cholinergic networks that represent the differences between folks with PDD from controls. And in the blue, what you can see is decreased binding in really the salient and cholinergic networks that are really responsible for multiple aspects of cognition. And in the red, you can see they're preserved or increased binding in regions in the frontal and the frontal parietal areas that are responsible for things like attention and visuospatial processing. So there's clear differences here, again, between controls and folks with PDD, again, later stage disease in these cholinergic networks. Moreover, if you actually give these individuals donepezil, right, so cholinesterase inhibitor, you can measure here on the right improved cognition on the MMSE over time, and that improvement in cognition maps on quite well to differences in the spatial covariance pattern within these individuals. And the thought here is essentially that you need some essential preservation of these key cholinergic pathways. One has a lot of overlap actually on the default mode network and these really frontal parietal networks. You need some preservation of these cholinergic networks in order to have a good treatment response to the cholinesterase inhibitor. So kind of a complicated slide here, but just step back. I want to just talk a little bit about how this might work as we think about acetylcholine even in earlier and cholinergic networks even in an earlier PD. So what I just showed you is some work on PDD and later dementia, but there's been a lot of work that looks at certainly the relationship between acetylcholine and attention and other cognitive structures in normal individuals as well as in folks with different psychiatric disorders and PD. Here though we just sort of take attention as an important construct. Attention itself, obviously not one thing, right? So it can be broken down to three main subsystems. So we have executive control, which is sort of top-down control over attention, and then some more fundamental aspects of attention, either orienting behavior or alerting behavior, really bottom-up functions of attention, right? So in PDD, in Parkinson's dementia, we've known for a while that cholinergic deficits here in the green can lead to disruptions in that very basic arousal orienting behavior. It can give rise to alterations in attention or those fluctuations in cognition or attention that we tend to think about as being common to the disease, and can have a downstream effect on other symptoms as well, including the manifestation of psychosis. But what we see as well is that earlier in the disease, we can also have problems with the cholinergic network that lead to disruptions in that top-down control over attention. Okay, and essentially there's this frontal parietal network that has projections, to and from the MDM, and it's this through this disrupted network essentially where you get these problems in executive control. And it can lead to things like problems in working memory, rule switching, response inhibition, that you, again, give rise to higher order attentional deficits. So, what we can see here is that cholinergic denervation can cause problems, again, in executive functioning that are not certainly due only to the dopaminergic denervation that we tend to see in the disease. It kind of has sort of this additive effect. Here we have some slides, so we can look at some postmortem studies as well. We have on the bottom row, there's the putamen. The middle row, you have the MDM, and then the medial septum and the DBV in the top row. And what we see here is that we're really looking at the number of choline acetyltransferase, which is really the presence of cholinergic terminals in a given brain region. We're looking at the difference between controls, folks with Parkinson's, and then folks with PDD. And sorry about that. If you can see here, if you look in at the middle row, there's a significant difference between the number of neurons that is specific to the NBM that distinguishes those with PD dementia from controls. All right, so there's about a 55% greater loss in neurons, again, specific to that region. But what's even more interesting, now I'll show it to you again, is that if we look at the acetyltransferase in the frontal cortex, we see not only a difference between those with dementia and controls, but we also see a difference between those with PD who are not demented and controls in terms of that acetyltransferase activity. Okay, so what this is essentially suggesting is that even though the number of actual neurons in those with Parkinson's disease, again, who are not demented, is not significantly different than those than controls, the activity, right, is the functional activity is. So there's a functional deficit, right, of acetylcholine in the frontal cortex, even though that the structural integrity of the neurons themselves are intact. So the thought here is that what we can really see here is that alpha-synuclein deposition in the basal forebrain might actually be affecting the cholinergic system, again, well before we see, or at least before we see that the neuronal loss in the NBM as well. So you really see this downstream effect of, and this dopaminergic denervation, again, before you even see a loss of neurons in the structure themselves. So kind of early microstructural changes can lead to cognitive impact in PD. Here we can see a cross-sectional comparison between patients with PD with and without cognitive impairment. And if you look here again, if you look at those who are cognitively normal versus those who are impaired, just at a baseline, clear differences between the NBM volume. And then if you kind of project out over time here, so over 36 months, you follow these folks, that there's a significant difference between those with, if you dichotomize those between sort of preserved versus not preserved gray matter volume in the NBM, those with lower volumes have a much more perceptive decline over time. And that this actually holds up even when you're controlling for other factors like hyposmia or other pathological factors, including tau, amyloid tau ratios, APOE. So it really seems to be a fairly independent predictor of NBM volume early on to cognitive impairment down over time. And even more interesting, again, on the right here, this is not, on the left is the gray matter density volumes, and the right is a measure of mean diffusivity. So this is really getting, again, at the kind of microstructural changes within the neurons itself. Again, so something that would precede structural damage or loss of neurons. And this is even a better predictor of cognitive decline over time. So there's going to be some very early measurements of within the cholinergic neurons of, pending damage that is seems to be a pretty significant precipitant of cognitive decline and development of impairment and dementia over the following months and years. This has been shown by others as well. I think what's interesting here is if you're looking at those with suspected MCI, it's at baseline versus controls. This actually breaks up the NBM into these different regions. So if you look at just the green bars, this is the posterior NBM. And it's this region of interest that is specifically difference between those with the early cognitive impairment and controls, which is exactly what you see in Alzheimer's disease, right? So these changes start really early on in the posterior area of the NBM and can be measured in terms of being statistically different. And then if you look at, again, NBM volume as a whole, just as we said before, those with lower volume have a more significant and more rapid decline and earlier time to diagnosis of MCI or dementia. And then this could be shown across a variety of different cognitive measures, measure TLT and semantic fluency. So it's not necessarily just one cognitive ability or cognitive domain that tends to be driving these declines over time, but we see a loss of ability in multiple different areas. I'll show you a little bit of work here too. So what we're trying to do as well is look in this study, not just in terms of does Ch4 volume predict cognitive decline over time, but thinking a little bit more carefully about which areas of cognition might be different, both early in PD and associated with cognitive deficits or predictor cognitive deficits over time. So what we did here actually in this study is we looked at two different cohorts. So we have a pre-surgical cohort here at UVA. It's a retrospective cohort. At the time, it was 125 patients, all who had pre-op MRIs and neuropsychological testing. And then the PPMI cohort, which is made up of over 200 PD patients and 101 healthy controls. And a subset of those, it was 100 who had 4-year visits with MRIs and neuropsych testing. If we look just first at the pre-surgical cohort, so again, think pre-surgical, think advanced Parkinson's disease. What we see here is that there's significant differences between those with, there's significant differences in terms of the attention and the visuospatial domains, okay? So these are really what stand out, okay? And then if you look at the de novo Parkinson's, the PPMI is I should say de novo Parkinson's disease, so it's early untreated PD, okay? We see that there's differences in the regions between on the JLO, so visuospatial functioning, right, letter number sequencing, so we have degree of working memory, and then the digit modalities T-score, so processing speed, okay? But it was actually only the single digit modalities test that was preferentially paired in Ch4. So these are regions we see significant differences between folks, that is noticeable in Ch4, Ch1, 2, 3, and the cortex, whereas the single digit modalities is very specific to this Ch4 region. So what this indicates here is that it's possible that these early changes in Ch4 volume could be tied to very early processing speed deficits. And we know that processing speed is really kind of diffusely or widely distributed throughout the brain, that you might be able to pick up on these deficits that are tied to cholinergic deficiency early in the disease, even in the absence of this neocortical atrophy. So potentially an early cognitive biomarker. So this is kind of what I just said here. All right, so that Ch4 was associated with attention to visuospatial dysfunction in both that early and more advanced disease cohort. But really, again, in that early PD, we see that it's these deficits in speed that might be unique. Outside of cognition, we also are gaining increased knowledge about the potential contributions of cholinergic loss, specifically in relationship between MEM volume and cholinergic loss and other neuropsychiatric symptoms as well. And here we looked at over 400 folks from PPMI, who had mean visits of 11 over 54 months. And part of this study, they had things from the geriatric depression scale, the autonomic dysfunction, REM sleep behavior questionnaires. So we're going to kind of a lot of different motor and non-motor measures from this study. And what I'll point out here is that when we're really looking at psychosis, that individuals here, what we know is that psychosis in general, in psychosis and PD specifically, is not just one thing, right? So an individual could essentially have one psychotic event, and the question is, do you consider that person to have psychosis and PD, and are they the same as somebody who has persistent psychosis for years, okay? We were able to kind of break this down into particular categories. So we can see here that in blue, these are individuals who had one psychotic event that happened to be at their last visit. in this kind of maroon color, we see that these are individuals who had one psychotic event and then reverted back to normal with no other events. In green, these are individuals that had a psychotic event who then never reverted, right? So sort of persistent psychosis over time. And then in the orange, these are individuals who had a psychotic event wherein that psychosis actually did remit, but then that was followed by at least one other episode of psychosis over time. So 4 potential sort of subtypes of psychosis, if you will. 33, just under 33% of the sample had at least one psychotic event, and about 20% reported more than one psychotic event. So again, as we know within PD, this is quite common. And what we're looking at here are some of the factors that are associated or infer greater risk of psychosis over time. And we see at baseline, those who had greater autonomic symptoms of REM sleep behavior disorder, other sleep dysfunction had a much greater likelihood of developing psychosis and 2 or more psychotic events over time, really a 3.7-fold greater risk. And then if you kind of map this onto, what we've been talking about in terms of MBM volume, we're essentially able to calculate Ch4 densities for 228 PD folks and controls. And what we can see here is that folks with participants with PD who had greater than 2 psychotic events had much smaller MBM volumes, right? So lower MBM volume at baseline is essentially a predictor, or is at least associated with the likelihood of having repeated psychosis over time in PD. And this was, again, specific to our region of interest, Ch4, wasn't found to have the same relationship in Ch1, 2, 3. And the last, what I'll show you here is this is a little bit of sort of yet to be published research here, so hopefully that changes pretty soon. But just some, I think, interesting work. There's literature certainly demonstrating that apathy can be manifested from a host of different problems. I'm getting a knock on the door from the custodian here. So dopamine denervation is implicated in apathy, and so is acetylcholine. There's not really many imaging studies that are really looking at the relationships between acetylcholine or cholinergic networks and apathy, certainly in PD. And what we were able to show here is that if you actually do get volumes from Ch4 volume, that we have quite a significant relationship between patient-reported apathy, this is measured on the Frisbee, and Ch4 volume. And then we also see a similar relationship when we look at the executive functioning scale on the Frisbee as well. We know that apathy and executive functioning are very highly correlated. There's a lot of work out there really showing kind of these are comorbid problems in general, but particularly in folks with PD. And the thought is that if we think about apathy, we think about both cognition and mood and other factors and behavior, right? So there's a motivational value essentially is attributed to both upcoming and behaviors and really the maintenance of goal-directed behaviors. And the orbital medial prefrontal cortex plays a significant role, as does the amygdala, in providing some context here in terms of, again, motivational value. And Ch4, these are areas where we say that Ch4 and the MBM have direct projections. So the thought here is that when there's a cholinergic loss within Ch4 leading to denervation through the prefrontal cortex and the amygdala, that can have this effect on motivational values and lead to what looks like the apathy that we tend to know and see in Parkinson's. We can also get apathy, though, not just from that motivational standpoint, but again, thinking about executive functioning here, our executive functions are really necessary in order to both initiate and maintain goal-directed behavior. And the lateral prefrontal cortex, certainly the dorsolateral and the ventral lateral prefrontal cortex are obviously implicated in executive functioning, as is the anterior cingulate. And again, here we see that these are areas where there are, the Ch4 has direct projections. So again, the thought being that this cholinergic denervation through these areas also contribute to the executive dysfunction and the manifestation of apathy and PD. All right. So in conclusion, kind of some take-home points here. I guess what I'm trying to stress here is that, PD is a heterogeneous syndrome, all right? So pathological heterogeneity contributes to unique PD subtypes. We know that dopamine is certainly at play. Nobody's questioning that, but we also need to think about the contributions of other contributions of other neurotransmitters to non-motor symptoms. Cholinergic denervation is, I think, in my opinion, clearly associated with cognitive decline and specifically with other specific cognitive deficits in both early PD and leads to a more rapid cognitive decline and conversion to MCI and dementia in PD. Ch4 degeneration really appears tied to a constellation of other non-motor symptoms that we know increases or infers greater risk for psychosis, like REM sleep behavior disorder. And that Ch4 degeneration is also associated with apathy in Parkinson's as well. All right. Just want to acknowledge my team and collaborators here. So Dr. Barrett really spearheaded a lot of this work with Jason Drusgel, our neuroradiologist. Another really great contributions from Jamie Blair, working in neuroradiology. Joe Flanagan, who was an RA working with myself and in our group. And then others in terms of some of the statistical design and biostatisticians, Dr. Smokin and Petrie, and some students that have done good work with us too, Justin Murphy and Jeffrey Zhang. All right. Julia, do you want me to give it to you here? Or
sure.
Another great lecture coming up. You guys should all join.
Thank you so much, Dr. Sperling. We do have a few questions that came up during your talk. So the first question is, with this newer understanding of various PD subtypes, what do you see as the role of neuropsychology in this population? Do you see that as changing or staying the same?
Yeah, it's a really good question. I think there's a lot of roles. I think it's about how we tend to think about our what our evaluation is for, how we can use the results for potentially for some for greater purposes, right? So beyond just calling somebody MCI or dementia, I think there's a lot of value into looking at clearly the cognitive domains or cognitive profile, but also trying to then take another step and really thinking more closely about why that individual might have that particular, not just cognition too, but really from a neuropsychiatric standpoint, a particular profile, and thinking about the differences in terms of potential differences in neurotransmitter dysfunction that might actually lead to that particular symptom manifestation. All right. So, as for an example, if we can think about this evidence that cholinergic denervation and Ch4 volume infers greater risk for cognitive decline, is associated with other significant neuropsychiatric symptoms, and we then also know that there are particular cognitive symptoms, greater posterior cortical deficits, deficits in semantic fluency, aspects of visuospatial functioning, memory issues that tend to be more closely correlated to the cholinergic loss. If we then see those particular symptoms, we might be able to then at least hypothesize that there's greater cholinergic deficits, which could have significance in terms of our prognostic value, both in our counseling patients. In general, you think about that certainly just in your kind of the run-of-the-mill PD evaluation, but also from a surgical standpoint, who might be at risk for having a greater cognitive decline if they're a surgical candidate or otherwise. And then, as I think, touched upon earlier, if we think about from a clinical trial design, I think one of the issues that we all know, not just in PD, but in general, is that if we have a very heterogeneous group of individuals, then it becomes quite difficult to tease out how well a potential medication or trial drug is working. You look at the cholinesterase trials that have been done thus far in PD. I think that's evident. And there's good indication that if you actually do good post hoc analysis and you look at individuals who have greater cholinergic, deficits, that they tend to benefit better in terms of both cognition and even a range of other psychiatric symptoms, certainly apathy as well, from these cholinesterase inhibitors. You see that in PD, you see it in AD, you see it in DLB. So I think we may not be doing much different right now in terms of what we do from a neuropsychological evaluation, but how we understand our results and how they're tied to the functional neuroanatomy, then that gives us a leg up in terms of the meaning that we can make from our exam, and being able to get that back to the patients and our other treatment providers.
Excellent. So the next question we got, so it says, very interesting research. You may have already covered this, but given your research, do you think that cholinergic loss and dopaminergic loss are consequences of the same neuropathologic mechanism? And do they follow the same relative depletion timelines? Or what about multiple pathologies in patients with PD?
So give me 3 questions at once. I'm supposed to remember all that. I'll try to unpack that a little bit, and if I don't, just tell me. I think some of that is we don't know. I don't think there's evidence right now that we can say like we can track essentially the timeline, from a dopamine to a acetylcholine perspective. As I was saying earlier, we know that dopamine loss happens in PD years before you ever see the manifestation of symptoms. If it's whether that's happening sort of lockstep with acetylcholine, probably not. But I think if you just back up and you simplify even a little bit from that, I think it's fair to say that at least in some of these individuals, you are seeing early cholinergic changes in the disease. The other thing about that is it's heterogeneous, right? So there's some data that it didn't show you, but it's not that everybody has significant cholinergic deficits. Whether you're looking at the brainstem pathology or more the sort of basal forebrain issue, that there's some individuals who are have normal volume and in both areas. Some that have greater deficits in one area versus the other. Some that are poorer in both. So it's a bit of a mixed bag. But you see the same thing really in PD just in general. It's not just this one one pathology or one manifestation of the pathology in the disease. So I think some of that's not known. What were some of you asked me a couple? Did I not answer one of the questions you just asked?
I think you got most of it, and I want to make sure we have time for other questions. So let's move on to the next one. Is it a priority to evaluate social cognition in the diagnostic process for PD? And what recommendations do you have about social cognitive assessment in MCI or dementia in PD?
Yeah, so good question. That's something that I actually thought of in terms of this work. I think social cognition, if you're thinking about, going up the ladder in terms of, executive abilities, it's certainly there. It's probably not an area where I'd gather say that is always evaluated, or that the bulk of neuropsychologists incorporate in terms of their standard evaluation. But it's not to say that it shouldn't be. I think it makes sense to be, as would always be the case if you're thinking about, your neuropsych eval, what are the bigger aims and goals that you have, and there's a long list of executive abilities, and an even longer list of measures that we have to assess those abilities. And obviously, what we do varies by the individual practitioner. Social cognition is not something that I I can say that I measure as sort of part and parcel of what I normally do for my evaluations, but again, it doesn't mean that I shouldn't do that. And I think we're certainly at a place in our field, I would suggest, where it makes sense to be thinking about what our sort of standard evaluations are, if you will, and ask those questions. Should we be doing something different? Should we be and if you have a good reason for it and can back it up, I think that's great. So there's certainly an important ability on a lot of fronts that has a direct impact on a lot of functional outcomes. So that I think the point's well taken.
All right, we've got one last question. Let me pull it up. So given the relationship between PD, neuropsychiatric symptoms, and apathy, is there heightened risk for suicidal ideation? And if so, how do you address this clinically?
Yeah. So I'm not aware of any literature that looks at that relationship. Actually, a lot of times with the apathy, it's different than frank depression. Certainly, and within PD and really beyond PD, you can see that that sounds obvious to say, but that increased risk of depression and suicidal ideation, it doesn't hold up quite the same way from an apoptotic syndrome as it does with depression. There's a lot of overlap between apathy and overlap between apathy and depression, but there are distinct entities. So that lack of motivation or drive to do things doesn't infer quite the same risk for suicidal ideation as does depression. So again, I'm not aware of anything on that front. I think suicidal ideation in and of itself is important to be assessing. You would for hopefully any one of our evaluations, but given that we're looking at typically a geriatric cohort with significant functional problems, significant cognitive deficits, neuropsychiatric symptoms, a lot of comorbidities. You want to be thinking about what the impact is on that individual and their quality of life and well-being, and if there's suicide risk that can be, that is something that you clearly want to be looking at. I think for all of our patients.
Right. Well, thank you so much, Dr. Sperling, for that wonderful talk today. And everyone join us next week for Dr. Katie Block's talk on neuropsychology, history, and systems. Thank you so much again, Dr. Sperling.